healthcare under our license with 100 business and community leaders from across our region joining us this morning. While I can't see you all, I know that you're there, and we're so grateful to have you this morning. Before I introduce our very distinguished panel, let me begin by thanking our partners and sponsors for making this program possible. First is the Chamber's own Healthcare Council, which is a group comprised of more than 60 dedicated healthcare professionals who meet monthly throughout the year to share best practices, referrals, and professional development. For the past few years, the council has been led by Deborah Samarajak, who by day serves as the administrator at Bishop Whitney Health and Rehab Center, located on the Wesley Village campus here in Shelton. Last month, Bishop Whitney was named as one of the nation's best nursing homes for short and long-term rehabilitation by U.S. News and World Report. Deborah, I know you're on the call this morning along with many members of the council, and we thank you for your continued engagement and support with the council. We're also pleased to partner with the Valley Council of Health and Human Services, which is a partnership of nonprofit agencies committed to providing high-quality health and human services here in our Valley region. I want to give special thanks to outgoing Chair Susan Agamy, the Executive Director of the Schooner House, our emergency shelter, where I'm so proud to serve as a director, and to congratulate incoming 2021 Chair David Morgan, President of TEAM, who's one of our distinguished panelists today. Finally, let me thank our wonderful sponsors, and we have 3 of them. First is PerkinElmer, whose motto is "For the Better." PerkinElmer is a global life science company that is enabling scientists, researchers, and clinicians to address their most critical challenges across science and healthcare. During this pandemic, PerkinElmer and its 13,000 associates have been working with laboratories across the world to overcome their SARS-CoV challenges by delivering the automation, real-time PCR, antibody testing, and vaccine development solutions they require. I want to give special thanks to another Chamber Director, Mike DeVito, who's site leader of the Shelton campus, 500 plus people on that campus. And Mike, congratulations to you on your remarkable 35 plus year career with PerkinElmer. Newtown Savings Bank, whose motto is "The Power of Local." NSB is a full service, independent community bank that has been serving Connecticut since 1855. Thanks to Bank President and CEO Ken Weinstein and his team, their extraordinary effort in supporting so many of our member businesses with their PPP applications and other loans under the CARES Act. And it's looking pretty hopeful that Congress may deliver a second act and badly needed support to our business community this weekend. And here's a news flash. NSB has just been named Best Small Bank in Connecticut by Newsweek magazine as part of their inaugural America's Best Banks 2021 ranking. So congratulations to you, Ken, and your team. And finally is the Valley Community Foundation, a leader in connecting private philanthropy and the long-term public good of the Valley and its residents. The Chamber is truly proud of its partnership with VCF, Valley Community Foundation, the United Way, and the Valley Council in establishing what we call the Valley COVID-19 Relief and Recovery Fund. Over the past 9 months, this fund has distributed nearly $200,000 to support a wide range of Valley nonprofits and frontline caregivers. Congratulations to Sharon Closius, the president of VCF, and to Valerie Knight, the program officer, for their noble efforts in response to this public health and economic crisis. So with that, we're going to begin with introductions to the first 2 of our panelists. We're going to start with Dr. Fred Browne, who's on the call this morning. He has many professional distinctions, including MD, MBA, and FACP, a fellow of the American College of Physicians. Dr. Browne is the Chief Medical Officer and Vice President of Medical Affairs at our award-winning Griffin Hospital. In this capacity, Dr. Browne has been a guiding light in the Valley community throughout this pandemic. He did his residency training in internal medicine and anatomic clinical pathology He's also fellowship trained at the Yale University School of Medicine in infectious diseases, medical microbiology, and epidemiology, skills that have served us very well over the past 9 months. Dr. Browne has been awarded professional fellowships in the Society of Healthcare Epidemiology of America and the American College of Physicians. He will be followed by Jessica Kristy, who I will formally introduce after Dr. Browne's remarks. So Dr. Browne, the floor, or I should say the screen is yours. Welcome, Fred.
Thank you, Bill. I really appreciate it, and I'm really happy to talk to everybody today. I see a lot of faces that are very familiar with the Valley Council. Sorry if there's any overlap. I apologize for that. What I want to do is sort of take this opportunity to. I have a few slides, but honestly, I really want to take the time to sort of couch the situation and sort of what we're currently dealing with. And I'm going to try to focus more on sort of the hospital, and then talk a little bit about the science around the vaccine, and then we'll pass it off to Jessica after that. So interesting enough, every year around October is when we see an increase in viruses. That's the natural progression. So that's what we typically see. So what happens is the summer, everybody's out, the weather's warm. There's a lot of UV light that can kill the viruses and potentially bacteria. Sorry, I got muted. So dealing with the viruses that occur in the community, as everyone starts to come back to school, comes back to work, and the windows and doors start to get closed, we get in a lot more close contact. As we get in close contact, this is how we start spreading viruses. We have close contact. We have close contact with schools. Usually in the September period of time. As it gets a little cooler, the schools come back. There's a mixing of viruses that come up. So relatively low amount of viruses that occur in the summer, all of a sudden they're starting to spread around a bit more. Schools, colleges, and then those end up coming home, and then that's when usually the adults start getting infected around the time of October. Theoretically, and again, sort of the way it's been going, this has not been that much different from COVID. So during the summer, we did see a little bit of a lull, but then we saw this uptick. And what had occurred was that we started opening things up, and this was inevitable. We had to open things back up. But as we opened up things, we sort of had I would say spots of COVID. So people were developing COVIDs. In particular, we saw it a little bit more in those who weren't as compliant as we'd like them to be. Not wearing masks, not social distancing. I like to blame the colleges, but it's probably just my theory. So what happened was we started to see more spread in that occurrence. What really happened next was, now you can imagine, if you can see sort of a map of colleges, a couple kids here and there. What then occurred is that we ended up having those young adults end up bringing that home. We started seeing clusters within the family. And I think that was exacerbated by a couple of the holidays, because the other piece that we deal with when we're dealing with, the fall, is we deal with the holidays. Starting off with Halloween, Thanksgiving, and now Christmas, we have all these holidays and Hanukkah and all the other things that get us together, at least potential holiday things that come up. So we saw kind of quiet before Halloween, and then when Halloween came, I could tell you, even from my personal observations, sort of driving around my town, I saw a lot of parties that were going on, and I didn't see a whole heck of a lot of people wearing masks. And I think that was part of sort of the start of this second wave that we saw. So we started this increase that started occurring, and we noticed in the community that we had an increase in positivity. We also know that this organism is very infectious, and I kind of a silly term. But from my standpoint, infectious means that if someone comes in contact with it that has not had it before, is likely to get it, especially if they don't wear a mask and they come into 6 feet away. So this is a very infectious organism. It's an organism, and again, people have talked about before, that humans really have never seen before. We've seen coronaviruses. We've seen a lot of coronaviruses. In fact, up to 40% of the people who have an exacerbation of their chronic lung disease is actually secondary to coronavirus. And about 5 to 10% of the people who end up having a upper respiratory tract infection it ends up to being coronavirus. So it is actually a common virus, but this type of coronavirus, and hence we call it novel when we started, is actually very unique. And because it's a unique virus that we've never seen, when we do come in contact with it, when we fellow contact with another human, that's when it starts to spread. And again, making it sort of in that category of being very infectious. So we started seeing a real bump up. And then once there's a bump up and you see this increase in the community, just by statistics alone and the way this works, the more people that get infected, the more the likelihood of getting people who are very infectious or getting very sick is possible. So even if there's 95% of the people who do completely fine with it, there's still the 5% that are going to end up getting sick. And of those 95% of that 5%, another 1% of that could potentially get really sick and end up being in the ICU. So we knew around the October time, as we saw an increase in positivity, we knew that we'd start to see some increases in the hospital. This has been a lot different than what we saw in April. In April, we actually saw a quick increase in a almost deadlier virus at the time, at least related to the hospital. Again, I'm sure later on we'll be able to talk about why that has occurred, but it's a lot different than what we saw. The mortality was really high. A lot of people were on ventilators, and unfortunately we lost quite a few people at that time. This one's been a little bit different. We've been seeing a lot of people who are infected. And I speak now from the hospital standpoint. We've seen a lot of people that are infected, but I can tell you that the vast majority of the people who actually come into the hospital end up coming here for a relatively short period of time, 4 to 5 days. They end up getting here, getting symptomatic treatment, and then going home and then continuing to recover. That being said, because just based on statistics alone, I can't sit here and say that we haven't had our cases, our deadly cases. And we've had 40-year-olds, 50-year-olds, 6-year-olds, and older that have actually succumbed to this virus. And again, I think that does occur. Sometimes we know why. Sometimes there's comorbidity associated with it. So there's people who are obese, have lung disease, have heart disease, have other issues that have actually probably helped facilitate the severity of this infection. But again, we've actually seen that. So that's what we've been seeing within the hospital. So what I wanted to talk even more about is the vaccine, because that's the newest thing that we have. So what I wanted to do is I'm going to share a slide here. And I want to talk about this vaccine versus other vaccines. Now, we've been giving vaccines, forever. I mean, starting off with the smallpox vaccine, we've been injecting people with different types of things. And just a little kind of side note about, vaccine. So smallpox is a great example of a vaccine. So smallpox, the way we were able to vaccinate against smallpox is that it was discovered that there was a similar appearing pox virus called cowpox. So at the time, the scientists at the time realized that the milkmaids who worked with cowpox were not getting smallpox. So what they did is they took a little piece of the cowpox and then they took that and they injected other people with it. What that did is it actually allowed the people who were not exposed to cowpox, they were able to develop antibodies against smallpox. It was cowpox and smallpox, but they were eventually able to develop antibodies against cowpox. And that's really the whole theory about vaccines. So the whole theory about vaccines is exposing a foreign protein to our bodies then develop antibodies to it. And then the next time that we're exposed to that protein, we have a rapid response. And we've been doing this now in a bunch of different ways for years. We've done things with live attenuated, where we actually take that genetic material.
I muted the video so you could eat in here if you want.
I think, all right. So we ended up, so as I was saying, so at that point, we were able to, give the protein to a patient. So we'd actually take a virus that we knew would get in, but didn't cause infection. We'd be able to put some protein into that, right? Use that mechanism, inject it into a person, and then that virus would replicate and then release the protein that we wanted to be released. We've made several modifications of that, and now we don't even need to use live attenuated vaccines. We can actually use regular vaccines. And essentially what we're doing is we're injecting a protein into the body, and then our bodies end up developing antibodies. Now let's talk about this mRNA thing, because this is sort of the big thing in the news. And this is what made people a little bit nervous about this vaccine, and I want to sort of dispel some nervousness associated with it. So we've taken out sort of the middleman in this one. So what would happen is that, you know, a virus or a mechanism, we would have the protein go in and then we develop antibodies. But what if we can actually figure out a way to tell the body to produce a protein? And that's essentially what's happening when we deal with messenger RNA. Messenger RNA is actually a normal thing that occurs in our body. So it's normal genetic material and it's normal in the process. So what happens is that our nucleus, our brain centers of each of our cells, sends information to ribosomes. Those ribosomes develop proteins, and those proteins then do their function. So what we did is we were actually commandeering that process, and that process from the nucleus to the actual ribosome is actually using mRNA. In the 1990s, we figured out that mRNA is something that we can use in a laboratory. So this is not a new process. We've been using this in laboratory since the 90s. So we found in the 90s that we can take this protein, this genetic code, this messenger RNA, and send a message to cells. And we've tested it through animal models. We've tested it through potential cancer treatments. We've looked at it in different ways. One of the issues that we found is that the messenger RNA that we would inject in animals would get dissolved very quickly. So we had to develop a package of information. So the first thing we did is so talking specifically about COVID-19, the first thing we did is we actually said, okay, what does the genetic code look like? And we actually sequenced that genetic code. And then we said, okay, of that genetic code, what piece actually develops a protein that will help us develop antibodies? So we discovered that. So we were able to put that code into a little, I like to say like a ticker tape, you know, you put it in a machine and then out goes the protein. So what we did is we send this little messenger RNA, we sequenced this messenger RNA, and then we started to synthesize these messenger RNAs that would end up going into a cell and then code out a protein. The protein that was the best protein to use in this case was the spike protein, the protein that actually attaches to our cells, injects the virus, and then the virus replicates within. So that spike protein, if that spike protein is not there, if we can eliminate that spike protein, then the virus can't replicate. So we developed this mRNA. But again, as I said, that mRNA can potentially dissolve quickly. So we had to figure out a mechanism to actually get it into the cell. And what we did is we put this lipid coating, this fat coating on it. And the nice thing about fat coatings is, so we have this synthetic mRNA, we have a fat coating around it. The nice thing about this fat coating is that it actually gets into cells real easily. So once we inject someone with this vaccine that has these little lipid coatings in it, then that lipid coating goes into the cells, and then this genetic code commandeers some of the replication process within our cells, and it starts to produce proteins. And as it actually makes these proteins will then be released from our body. And now we have these spike proteins that are circulating right now in our body, probably circulating right now in my body. I just got the vaccine a few days ago, circulating in my body, and my immune system is attacking it. And as it attacks it, it actually starts to develop memory. And that memory is what we ultimately want to do. Now, if you can imagine, you know, if you just got injected with protein, once that protein's gone, that's about it. But if you actually have a system that replicates for a few days, then you can imagine that hundreds and hundreds of these little spike proteins, well, millions, I should say, hundreds, millions of these spike proteins are actually being produced in your body, and you're getting antibodies, and you will develop antibodies. It also makes sense that if you're developing these foreign proteins, that you're likely to develop some sort of side effect. And side effects are not necessarily a bad thing. I mean, it sounds like it's been relatively low, but some soreness, you know, maybe a little bit of body ache, some fatigue. Those are actually signs that your body's fighting off a foreign protein, which is really good. And you can see, given this mechanism and commandeering this mechanism, this can be a really effective way to vaccinate a patient, because again, they continue to have this protein that's produced. We have antibodies that are developed, and then now we have this memory. So when a real viron comes in that has these spike proteins, we attack that so fast that it never even enters a cell. So that's actually where we are now. And I hope that actually makes some sense to sort of understand where we are. So there's basically 3 companies that are developing vaccines. The first one is Pfizer, as you've heard about. It's kept at -70, so that's actually currently why we're doing it in the hospitals, because we have the -70 freezers to manage it and manage the distribution. Moderna just ended up getting approved this week, and we'll start seeing that one. That one is also an mRNA vaccine. So Pfizer and Moderna both have mRNA vaccines. That one doesn't need to be kept at -70, so we'll be able to get that one out. Hopefully our health districts will be able to use that one. And there is a third one that's developed by AstraZeneca, which is actually being done in the traditional way. So it's actually going to be used in what we're using as a vector, and that is an adenovirus. So that's something that's actually going to be occurring. It's really important as we move forward with these vaccines, it's really important that we start to get this out. And since we don't have, and we have a lot of viruses, a lot of vaccine that is being produced, it's important that we phase them out. And again, I think if you're not familiar with this graphic, again, phase 1, how do we get this to the healthcare workers? How do we get this to first responders? How do we get this to people who sort of have direct contact with COVID-19? It's funny because we talk about exposures, yet, someone like myself is an infectious disease doc, or like my wife, most of you know my wife is a pulmonary critical care doc. I mean, we are exposed every day. So the question is that getting that vaccine out? And then as we go to the 1B, we start to look for the higher risk, and then we slowly phase this out. Again, as more vaccine comes, the more we can see it, the more we actually can actually get this to everybody. With the ultimate goal being is that we really want to develop herd immunity. I think that's really important. And I think that's a topic that's been thrown out a lot. And I think there's a lot of numbers that have been thrown. Essentially, what we need to do is we need to have 40 to 50% of the population have antibodies against this virus to really have herd immunity. And so you understand what herd immunity is, and then I'll end on this. What herd immunity is that if you go into, so as I mentioned in the beginning, let's start this way. I mentioned in the beginning, this is a novel virus. We've never seen it before. But if the majority of the population, or at least over 50% of the populations, have seen it and has developed antibodies, then next time you go into a group, if 50% of the people have actually already had it, the likelihood that you're going to be able to spread it to someone else is actually be that much less, because you may bump into someone who has already had it. So if I don't have the virus, right? I've never had the virus, but I go into the room and there's, 50% of the people actually have already had the virus. The likelihood that I bump into the person who doesn't have antibodies and has the virus is actually that much lower. So that's what herd immunity is. Now, you'll hear different numbers related to that. Natural immunity versus vaccination. If you put the two together, that really is herd immunity. There's still some issue about, what's the long lasting and what's the effect of natural immunity. So does natural immunity confer for a long period of time? Does it really do it? Can you get reinfected? All those are questions that are still out there. When actually, if you get the vaccine, then you're basically, that's synthetic way of being herd immunity. So the more people that get the vaccine, the less likely it'll be spread. So even if you don't get the vaccine, then the possibility of spreading it is that much lower. Now, we're obviously encouraging, everyone who is at risk, and I define everyone at risk as, really an age issue. So everyone at risk, 60 and older, the risk is high to develop. The risk can be up to 10% where you can have a mortality if you get it. So if you're even in that age group, I think this is one of the things that you definitely should be getting. I think any risk factors, any health issues, all of there. I know some people have been waiting, but I can tell you that most people, if you're concerned about side effects, we've had minimal to no side effects recently in our first week. So it's looking like we're doing really well. So I'm sure there might be a few questions afterwards, but I'm gonna go ahead and end there. Bill?
I think so. Thank you, Dr. Fred. Thank you very, very much. As Fred pointed out, Griffin began administering COVID vaccines to caregivers this past Tuesday. And Dr. Browne was among them, so a very hopeful sign indeed. Thank you so much for setting the stage with the science, which is so important. We're going to move along to our second speaker, and we do have some questions in the chat box, and we do urge you to do so, and perhaps we'll take them in turn following Jessica's presentation. So let me introduce Jessica Kristy, MPH, who's the Director of Health at the Naugatuck Valley Health District, NVHD, the nationally accredited local health district serving our 6 Valley communities. Jessica also serves as Director of the Naugatuck Valley Medical Reserve Corps. Jessica's regular and comprehensive COVID-19 case summary reports have provided vital information to our municipal leaders, our nonprofit leaders, our Valley residents and businesses, and for that, we're very grateful, Jess. Jess earned her Bachelor of Science degree in Safety Studies from Keene State College, where she focused on occupational safety and health. She concentrated her Master's of Public Health degree in Environmental Health Sciences and also received a graduate certificate in Emergency Preparedness from New York Medical College. So we're going to turn it over to you. Dr. Browne and Jessica have worked very closely together throughout this pandemic, and we're truly honored to have you with us this morning, Jess. So the screen is yours.
Thank you, Bill, and thank you, Fred. Good morning, everybody. I am going to pull up some slides here. Okay, I thought that what I would do this morning is just give you a little bit of an overview from the health district point of view. Thank you to Dr. Browne for talking about the hospital side and really getting into the science behind the vaccine. The health district plays many angles in this pandemic response, so I thought I would just kind of give a high-level overview of all the different moving pieces that our staff have been focused on. And I quite like this graphic here that we're knocking out COVID-19, just taking it one day at a time. I know all of you members of the Chamber of Commerce and Valley Council and just in our day-to-day lives have been impacted one way or another. And I just want to thank everybody for really coming together as a community, being a little bit creative with our businesses, and really adhering to the guidance that's out there. It is making a difference. We just need to keep at it just a little bit longer. Since we have so many businesses with us this morning, I thought I would just give a quick reminder here that the DECD website is a really great resource for our sector rules. And these are what the state has kind of provided to us and our different agencies and businesses as parameters to really comply with some health guidance while still being able to operate during this significant pandemic. Right now, we're in what's called phase 2.1. It's sort of a mixture of what we saw in phase 2, but a little bit backtracked from where we were in phase 3. This reverted back at the beginning of November, and we're hopeful that with the introduction of the vaccine and sort of getting over the hurdle of the holiday season, that we might be looking ahead to some future reductions in the sector guidance. So the DECD website is, again, really great resource. It breaks things down. There's pictures. If you have not browsed it already, please do so. There's also just really great information for the general public as well as it relates to private events and sort of daily life. I wanted to pull up this map here, and I'm sure many of you have seen this from the governor's press conferences or in our reports locally. But what the State Department of Public Health had done was move to a 2-week reporting period, and then adjusting the cases on a per 100,000 population rate. And what this does is it kind of gives you a more fair playing field between the towns. A small community like Derby versus a larger population in a town like Shelton, may mean different things when you look at the number of cases. So this kind of puts it on an even keel and allows us to look at things a bit more fairly across the communities. I included the 6 valley towns covered by the Naugatuck Valley Health District. I also included Oxford, as Oxford is a member of the chamber. So as you can see, Ansonia for the last reporting period had a positivity rate of 71.3 per 100,000 population. Beacon Falls 46.2, Derby 61.1, Naugatuck 77.2, Seymour 45.4, Shelton 50.8, and Oxford 48.6. Last week, this map had, I think, 6 towns that were still shaded gray, which means they had somewhere between 1 to 5 cases per 100,000. But as you can see now, this is significantly less gray towns. So I think it's 166 towns are in the red on this map, which also attributes to more people being tested and kind of the lag of the positive results that came after the Thanksgiving holiday. When we look at the ages of the people who are testing positive, the Valley has kind of matched the state data here. You can see the bars in the both graphs kind of follow the same ups and downs. So we have had, less people in the 0 to 9 age group relative to the 20 to 29 or 50 to 59. When we were really in the thick of it back in March and April, a lot of our population was testing positive and living in long-term care settings or assisted living facilities. Then we kind of saw it even out a little bit, and then really starting to pick up, like Dr. Browne said, among families and people traveling and things of that nature. A lot of our Valley families live in multi-generational houses or are really kind of a lot of people in small living quarters, which is not a very great thing for this highly infectious virus. So we're starting to see the younger population really increase there. There's also, increased testing, so that also factors in. When we talk about the pandemic, we also need to think about the community members that we have lost. Unfortunately, in the Valley, when we look at the death data, we have to date seen 263 of our residents pass away from COVID-19 complications. When we report laboratory confirmed deaths or probable COVID-19 associated deaths, this is not to say that COVID-19 was the sole cause of someone passing or the main factor of someone passing, but it is a significant contributing factor. Naugatuck Valley Health District draws out our laboratory confirmed deaths from the probable deaths, whereas the state reports these as one combined number. So we really like to get in there and see were they tested either before they passed or maybe post-mortem, or were they not tested at all, but the certifying person did determine that COVID-19 was likely a contributing factor. We did this past week, unfortunately, announce our first COVID-19 associated death among a Beacon Falls resident. Again, the deaths aren't as high in volume as we were reporting in the spring. It was very sad to write our daily reports and announce handfuls of deaths at a time, but nonetheless, we are still seeing them. So about 87% of those deaths have been among nursing home residents. When we look at the age groups of the people who are passing, they are our elderly population. A significantly higher amount of those 80 years old and older contribute to our local numbers, which again matches the state kind of pathway as well. We have had 4 people with laboratory confirmed associated deaths in the 40 to 49 age group, as well as the 50 to 59 age group. And then if you can see the slides, we had 19 in the 60 to 69 age group and 49 in the 70 to 79 age group. So we keep an eye on this and we track it. We also track it by age and gender. But again, locally here, our data is consistent with what we're seeing statewide. I have to plug our partners at Griffin Hospital's testing. Testing is important and testing is available. Anybody who wants to get tested should call the Griffin hotline to schedule an appointment. Please have your insurance ready, although you can give a promo code community so you won't need a doctor's order. You can schedule an easy appointment and drive right up at Griffin and get swabbed, and then you will be notified of your testing results. Griffin has also started doing pop-up test sites, which have been extremely helpful for our community partners. And I'm sure some of you know people who have either gone through the testing or gone through it yourselves. I also want to just put a plug in here for 211. It's a really great resource for many things, but you can also go right onto their COVID testing site and look for a test site near you or that's available for appointments or non-scheduled drive-up appointments. It's important to still know that while you may be tested, especially if you're symptomatic, you should stay home until you receive your results. We often find out during our contact tracing interviews that people feel unwell or maybe like they have some symptoms of the common cold, something that they experience every year because we live in Connecticut, New England, and colds are common here. They get tested, they shrug it off, maybe go about their daily life, go back to work, do whatever, and then they get the result the next day and they're positive, and that makes contact tracing that much more complicated, and that puts that many more people at risk of exposure. So it's really important to stay home if you are positive, waiting test results to know if you're positive or not. Once we receive the test result from the healthcare provider or the lab, we receive it in a surveillance system that is secure and online. And it also matches our contact tracing platform software. So eventually someone will get created a individual unique profile, and the contact tracers will be able to see this positive result. And we're looking at molecular tests like the PCR tests, as well as antigen test data. So when our contact tracers are calling the positive individuals, they're conducting really thorough interviews with them. First and foremost, we want to know, how are you feeling and do you need any resources? Is there anything that we can help you with? We want to explain to them what isolation means and what quarantine means. Isolation is keeping a sick individual isolated from other persons in the household. Quarantine is keeping those who may have been exposed away from the general public while they may be incubating the virus but not yet know it. The incubation period for this virus is 14 days. It's quite long. There are viruses that have even longer incubation periods and quarantine times. Like when we were talking about and dealing with Ebola a few years ago, we were looking at a 21-day quarantine period. There are other viruses that are shorter. Guidance was recently changed on the CDC website at the beginning of this month. We have been working and really receiving guidance from the State Department of Public Health on how we might be changing those parameters locally. So stay tuned for that. We'll be putting out an announcement, as well as working with our school-based partners to ensure that the State Department of Education publishes their guidance so that everything matches and we're all on the same page. When you are testing, please ensure that your proper contact information is included. We often get reports that are incomplete or have misinformation. And this really affects our data, but also our ability to connect with the people who are positive. And when we're doing contact tracing, time is of the essence. And what I mean by contact information is we'll get addresses that are no longer valid. So maybe someone has moved out of the valley or out of the town, or to a new address, and that really can affect our ability to communicate. Phone numbers may be inactive. You know, maybe people aren't giving their birth dates, or they're incorrect. So even if you're going to your primary care provider, or somewhere where you've been before, a doctor's office or a test site, just double check, because that can really save us a lot of time on our end. Dr. Browne mentioned 3 of the vaccines. I'm just going to briefly talk about 2 of them and how they relate to the health district, and kind of what our role will be as we look ahead to the next couple weeks. Right now, we're in phase 1A. As Dr. Browne mentioned, hospitals like Griffin have started to receive their doses of the Pfizer vaccine. This is the ultra cold vaccine that requires special storage. I think 9 hospitals in the state received the first doses, and started vaccinating their healthcare workers. Hospitals will also be working to vaccinate our medical first responders, such as our EMS partners, those with certification through the Office of Emergency Medical Services at the state. Now, with the approval of the Moderna vaccine, local health departments will also start receiving vaccine as early as next week, which is really exciting news, but also coming really fast. We had anticipated that we would start receiving this vaccine after the new year, although that's okay. So there are things that we are doing in the back end to prepare for this, and we are extremely fortunate that we have open lines of communication, both with our critical workforce partners here in the Valley, but as well as the state and the federal government to help us through this process. Those who are considered to be critical workforce in terms of the phase 1B definition of that will include agencies like fire departments, police departments, municipal workers, Board of Education employees. Sort of that grouping is who the health departments and local health districts will be first providing vaccine to, and will be providing the Moderna vaccine. Eventually, once we start getting larger shipments into the state, we will be able to start expanding that out into the over 65 population, the under 65 with other health issues, and looking ahead at that. Part of phase 1A also included long-term care and skilled nursing facility staff and residents. That was through a contract with the federal government, CVS, and Walgreens. So our pharmacy partners at the corporate level will be giving out the vaccine to those agencies and those partners. If you are part of either the phase 1A or phase 1B grouping, you'll be working with the COVID-19 vaccine provider, which could be Griffin Health, it could be Naugatuck Valley Health District, to upload employee roster and information into a system called VAMS, the Vaccine Administration Management System. This process, admittingly, has been a bit tricky. It was overwhelmed very quickly, so the system is on a bit of a delay. But this is what we are using here locally in the Valley, both from the hospital side and the health department side, to order our vaccine, track our vaccine, schedule appointments with our employees and patients, to do online registration and consent. So all of the information is kept in one central location in this VAMS portal. Those of you who may go outside of the Valley to get a vaccine may be utilizing something like Epic or their other electronic medical record system. But typically, most people who are providing vaccine across the state of Connecticut will be utilizing the VAMS system. So stay tuned for more information. And as we are getting prepared, we will be reaching out to those critical workforce coordinators to help upload those employee rosters. When I know there was a comment in the chat box about the general public and receiving vaccine. So while It's great that the Moderna vaccine is coming earlier than what we anticipated. We're still receiving very small quantities of doses to the state and then to the local level. So let's say, I put an order in for 5,000 doses to do a certain number of critical workforce employees. I may only receive a couple hundred doses. So it's going to be a slow rollout process, which will require a bit of patience, especially those in the 1A and 1B grouping. But we're hopeful that we'll get to the general public later this spring and early summer. So I think the governor's task force had anticipated around June or July. And we are still waiting for guidance from the State Department of Public Health on whether or not we'll be utilizing the VAM system for the general public or moving away from it and running them more like we do our seasonal influenza clinics with registration and scheduling at the local level. So as we get more details about the general public and what the vaccine will be, what it will mean for them and when it will be available, we will certainly share that information. Running our clinics and doing this work is going to be no easy feat. We have a lot of people here in the Valley. Just our 6 towns alone is 126,000 some odd population. So we are calling upon volunteers, those who are really able and willing to lend a hand to help us. The Medical Reserve Corps, which Bill mentioned I coordinate, is a national network of medical and non-medical volunteers. So the name is a little bit misleading. Sometimes people forget that we have non-medical volunteers as well. But anyone that's 18 years or older and wants to assist with these efforts can go right online to ctresponse.ct.gov and make a profile. And then essentially what it will do is it will ping the town of where you register, unit leader, and we will swear you in with an oath. Picture, you can see the picture here. That's something that we do so that we provide our volunteers liability coverage under Title 28 of the general statutes. And then we create missions and activate our volunteers. So we're fortunate that the governor had added the executive order to increase the number of people with different specialties who will be able to help vaccinate. So that's our EMT partners, our dentists and dental assistants, podiatrists, veterinarians, and so on. So even if you don't have medical training, but still would like to help with maybe like traffic flow or administrative support, we'd certainly love your help. And I coordinate all of the volunteers in the whole Region 5 there. So you can see on that map, the state is broken into 5 emergency planning regions through the Division of Emergency Management and Homeland Security, or DEMIS for short. Some of our Valley towns are also in Region 2, so we also look at coordination there. As we look ahead to the next set of holidays, and now that we're in them, I just want to put a gentle reminder there. If you don't have to travel, please stay home. I know it's extremely hard being away from family and friends, especially during the holiday season. I get it. I wish that I could be with my family and, celebrate as normal. But unfortunately, we're just not quite there yet. So virtual participation in meetings and things have been great. I know some of us have Zoom fatigue, even as we're on a Zoom here, but sometimes just a quick video conference with family members, especially our elderly family members, can make a really big difference in our mental health and just how we're feeling. As a reminder, we want to still practice the precautions that we've been announcing all along. First and foremost, hand washing and proper hand washing is key. It works. Making sure that we're thoroughly washing our hands for at least 20 seconds, that we're really washing the tops of our hands and bottoms and getting in between the fingers throughout the day. It can make a really big difference with keeping our hands clean and keeping our hands away from our face. Wearing a mask properly. Whether you are going out into the public or being around someone who is not a part of your family within your household, or whether you are a business owner and you have employees or patrons coming to your establishment or organization, it's really important to ensure that proper mask wearing is taking place. So you want the mask to cover your nose and the mouth and stay on. It's hard to not fidget when you have something on your face like that, but it's really key. Once you set it, you want to try to set it and forget it and not touch. Keeping 6 feet apart is also very important. And you'll see, when you're walking around stores or going places, markers on the floor or, spots to designate that 6 feet distance. And that's on purpose because we know that this virus is really highly contagious. And the further apart you stay from someone, the better chance you have of not contracting the virus, even if they don't seem symptomatic. And then avoiding large crowds as much as possible. When we look at the emergency management cycle, there's 4 key phases: mitigation, preparedness, response, and recovery. We're kind of in these last 2 blue and green phases running simultaneously. So we're for sure still in the response phase and kind of riding the wave, so to speak, of the pandemic. New things come at us every day. Cases rise, cases lower. Testing capacity is really great one day, and then maybe it's a little bit backed up following a community event or holiday. So we're definitely still looking at the response. We're also looking ahead to recovery. I've been very fortunate to have really great partners here with team and a lot of the Valley Council members who have hosted local events and efforts to really impact our community in a positive way. And I'll let David speak about that when I turn it over to him. But I do want to let you know that the state is looking at recovery already. Usually we wait until an event is done before we start thinking about short and long-term recovery. But with this pandemic, we know that there's been significant economic impact, personal impact, things that are going to be changing the way that we do life moving forward. So there is a statewide long-term recovery committee. There's regional long-term recovery steering committees under ESF 14. And then there's subcommittees working on many different projects to survey what we really feel our unmet needs and challenges are at the moment. So if there's something that you're experiencing or need help with, please let myself or David know so that we can ensure that we address it as part of that recovery project. But also know that when we're conducting contact tracing, we're able to connect our community members with a person in a position called a community resource coordinator. So if someone isn't able to go grocery shopping because they are in quarantine or in isolation, and maybe they don't have access to a delivery service like Peapod, those people can connect them with meal delivery. Or maybe it's rental assistance because they're not at work and they're nervous that they're not going to be able to pay rent this month. Maybe it's they don't have access to a thermometer at home, so they need help obtaining one so that they can take their temperature. So all those kind of things are also being provided at the individual level, but then as a community. And I think that's where I'll end right now and turn it back to Bill so that he can hand it over to David.
Thank you, Jess. Thank you very much. We do have a number of chats and conversations going on, and we're gonna hang on to them because we have 2 wonderful speakers that I want to get to right away. Next up, and Jess, you teed it up beautifully. David Morgan is the president and CEO of Team Inc., which is one of the Valley's leading human service organizations, serving more than 11,000 residents each year. David is an accomplished and a devoted advocate for the economically disadvantaged and our vulnerable populations. His passion and expertise has been sought out by governors and legislators, both past and present, to serve on various human service committees and commissions. He's nationally certified by the U.S. Department of Health and Human Services and collaborates extensively on areas such as early childhood, senior affairs, and anti-poverty measures. Currently, David is a member of the steering committee for Connecticut's COVID-19 response and recovery efforts for Region 5, which is outlined in the slide, which includes the lower Naugatuck Valley, Waterbury, Litchfield County, and Danbury region. So David's going to talk about the human resource and human services, the impact here in our community. David, the screen is yours.
Thank you. Thank you, Bill. So welcome, everyone. I'm going to shift gears and I'm going to give a very cursory kind of 30,000-foot level from a human services perspective to connect the dots from what we heard from Jessica and Dr. Browne. So again, here's, through the lens of the focus groups and the frontline experiences 10 months into this pandemic, here's the headliners that when we see about the challenges and circumstances bearing down on our Greater Valley residents and neighbors. Number one, employment and the economy. And again, it really stems into the avoidance of the long-term unemployment, reflect on those record smashing unemployment numbers that absolutely shattered any unemployment trends and numbers, even from the Great Recession when you look at 2007, 2008. And the key here is understanding, when you look at those numbers from March to May, as well as into June of 2020, and you look at the extension of unemployment benefits, the extension of 13 weeks onto 26 weeks, going 39 weeks. And so we are entering this window now where we want to look at people who are falling in off of that cliff or falling into this status of long-term unemployment. And the research and the data and past experiences is very clear how hard it is to recover when you fall into that long-term unemployment. And I think 10 months in, I've talked about this often, this theory, this light switch theory that we would hear a lot about COVID-19. We'd switch things and everything would be right back on. I think we can all agree that the light switch theory has been disproved. And we want to be very careful about the false comforts of extended benefits for residents and neighbors and people most affected by the impact of COVID-19. And obviously the larger ecosystem of the businesses, small and large businesses, restaurants that we've lost, some we've lost forever, some are just struggling to get by, and what that does to the economic vitality of the region, and for people who are trying to, their livelihood and way of life for themselves and their household members. Number two, food access and other basic needs. Food has been and continues to be the number one headliner in the area of basic needs. And again, that is no surprise. It starts with food. Number three, housing. And the other related needs around utility and energy. There has been a moratorium, a federal as well as a state moratorium that does not allow evictions or shutoffs on utilities, or electric, heat, water, in other households. The federal expiration actually expires December 31st. So we are certainly in a, and just wait 20 minutes, anything can change, as our federal Washington, D.C. and Congress is working on the latest relief bill that will momentarily shed some light on where that can go. There are prescriptions in there around providing funding relief, not only for residents, but you also have to think about landlords, and you think about their livelihood and how long that whole economic engine has just been in paralysis, and it's not fixing it. It's really just delaying. These moratoriums continue to delay this issue that really becomes such a tsunami of need for people who have not been able to pay their rent or their mortgage at the level they could have, whether they were laid off or experiencing furloughs or other impacts from COVID-19. And then the flip side of the landlords, and you think about their role in the economic vitality of the region. And so part of the relief bill that at the federal level, and again, the timing of this presentation, things can change very quickly, just within days and weeks. That does include federal relief as well as potential extension of the moratorium. Literally just yesterday, the governor for the state of Connecticut, Governor Lamont, announced the extension of Connecticut's moratorium. So many may be thinking that for Connecticut, we're hitting a cliff after December 31st, but literally within the last few 24, 36 hours, that was announced, the extension of the housing moratorium to February 9th, which actually coincides with the remainder of the Governor Lamont's executive orders. So that gives a little, again, it just delays. There's still a lot of uncertainty, and it's a very eerie calm around this devastating impact around housing for people in our Valley region and the landlords. Childcare is another one. Many have learned in this pandemic, if they didn't know before, they have very quickly learned that childcare is an essential element to the economic vitality of a working community and for the state of Connecticut. 1 in 3 of our workers are parents in our state, and we saw the impact of when schools shut down. What did that mean to the to working parents? And childcare, young children, school-aged children. You think of childcare providers, YMCAs, Boys and Girls Clubs, many other amazing institutions that provided care for hardworking people and working parents. And not a week goes by where, as we navigate the COVID-19 response and recovery work, where we can immediately hear from working people, my child's childcare classroom had a COVID-19 related instance, whether it was a positive COVID-19 or a quarantine decision. And so just within minutes, a childcare capacity can be reduced. A classroom could get shut down for 14 days or more. A whole childcare center, daycare can get shut down. And what that in the ripple impact that has to working people and to businesses has just been extremely challenging for the economic engine for our region as well as Connecticut. And then lastly, this seems obvious, but I would argue that this is the one that needs to permeate on every page, and it's really the physical health. You heard from Jessica and Dr. Browne about the devastating impact to health and wellness, the loss of life, and then the other piece of the behavioral health and emotional well-being. There will be a psychological pandemic. I am, not only concerned, but also equally optimistic because of what 2020 has taught me and our community partners and family and neighbors. So concerning yet equally optimistic because of what 2020 has taught us. And then I'm gonna quickly accelerate here so we can continue on with any questions and turn it back to Mr. Charmel and Bill. Again, I'm gonna skip this one. This is a snapshot of our our Greater Valley region just months before the pandemic came crashing down on the Valley, and sheds light on issues that we were really strategically and collectively from public and private sectors coming together and working to comprehensively address. And some of the sobering realities in the Community Index report unveiled by the Valley Community Foundation, Griffin Health Services, the Naugatuck Valley Health District, it's a very long report. I just pull out a sobering piece of the report. The poverty rate increased, the low income rate increased, the median household income declined, 36% of the region was cost burdened, 15% severely cost burdened, meaning they're spending more than 30% of their resources for the roof over their head. The 15% severely cost burdened, they're spending more than 50 cents to the dollar of their resources for that roof over their head. And then lastly, the ALICE threshold, which is even more realistic because it looks beyond the poverty level. It looks above the low income threshold, which Connecticut defines as 200% of the federal poverty level. And it really looks at the true cost, the actual cost of healthcare, taxes, the actual cost of food and transportation, housing, and what remains for an individual for their own quality of life. And what the report revealed is a significant portion of our Greater Valley region may be above the poverty and low income rate, but is still struggling to meet basic needs for themselves or their household or their family members. Again, this is a snapshot before any cognizance of a COVID-19 pandemic crashing down on Connecticut and certainly on our Valley communities. I'm going to skip this. This is, and please, you can pick at my brain later, or reach out to Bill and I'd be more than happy to dive into the intersectionality of social and economic well-being and what a driver that is to overall population health and wellness. The unemployment, these are the numbers as I shed light, as I spoke to unemployment, and I'll show you more specifically unemployment impact. And this shows you through June on the COVID-19 unemployment impact compared to what unemployment was in December 2019. And I had a slide for September and October, and I was a bit cynical, and because I didn't trust the numbers. This is not an exact science. There are definitely some flaws in analyzing unemployment data, but there is still realities of the trends that really paints a picture of what COVID-19 and its impact to unemployment has had. Right hot off the press, you will see the November numbers, which just got released within the last 24 hours. The unemployment rate, I'm sad to say, from the October number, it has shot more than 2% in the state of Connecticut. So that's really starting to shed light on the long-term and continuing impact of COVID-19 on unemployment. And here's the October number where it showed a decrease. But again, we just shot up more than 2%, I'm sad to say, for the November data. I'm going to show you a few images and close it up, Bill. So these are just some images of right here in the valley. You can see on the top here, we have 5 champion food pantries that have been in the front line for 10 months now, working alongside many other Valley Council for Health and Human Services providers, including TEAM and many others. And just to give you a snapshot, on a monthly basis, when we collect the monthly data from the 5 food pantries, distributing more than 64,000 pounds of food, that's per month. That's per month. And the amount of people accessing those food pantries is just under 2,000 right here in our Valley communities, predominantly from Ansonia, Derby, Shelton, Seymour, and Oxford. Poundage, about 1.2 meals on about 1.2 pounds equals a meal. So that's about 53,000 meals per month. In the lower level here, when you look at the larger region, you look at the work that Griffin Health Services, TEAM, many other community-based organizations have been doing around the Accountable Health Communities grants. You look at the patient screening data, so patients going into a healthcare entity for health-related needs who have been receiving social screening questions like, what is your housing situation? What is your access to food, your transportation? Do you have children in the home? Other social questions beyond the health and wellness questions. And you can look at the screening data here from July 2018 to July 2020, over 2 years. The #1 health-related social need identified in those screenings has been food. The other big headliners, by the way, after food are transportation and housing. But I want to focus on food here. So if you look at the bottom from March 2020 to July 2020, so if I just pull that high impact time period of the coronavirus impact, it jumped from 50. So from 1 out of 2 identifying food as its #1, it jumped up to 2 out of 3. A significant increase in the need for food is my point of showing you the data here with the Accountable Health Communities health social screening data. And then some of these images, these images on the right side, this is literally just from 1 week ago, this very time, where we are continuing to coordinate as a Valley region, public and private coordination, law enforcement helping direct traffic. We moved more than 36,000 pounds of food in less than 4 hours to more than 900 cars coming into Nolan Field in Ansonia. Residents and households from throughout the valley, our largest numbers from Ansonia and Derby, as well as the coordination of getting meals delivered from this USDA food drop to frail, isolated elderly, disabled, other households who could not otherwise access Nolan Field or other food pantries. This is on the left, you can see an image of Meals on Wheels in Derby, pre-pandemic, and you can see what it looks like post-pandemic. And again, the pandemic has resulted in more than doubling the output of home delivered meals to older adults in our Valley region, 216% increase. This is an image of what childcare looks like and how difficult and complicated childcare has become to do amidst a pandemic, has been and continues to be deemed essential. And then lastly, I'm going to close with the headliners again. And Bill, I can share this this PowerPoint beyond. And I'm very inspired I don't want to come across as rainy and full of clouds, but I'm very optimistic because of what 2020 has taught us about ourselves and our communities, and about resilience, and how we've learned to face and weather unprecedented challenges. And we've learned that we can be adaptable and creative, and to experiment and innovate, and to think out of the box and make it happen together. I'm inspired when I see a 14-year-old youth from the Seymour Leos Club or the Seymour Lions Club stand beside me and move more than 36,000 pounds of food to people in need. Where I'm inspired to see a 17-year-old who's making masks out of her own time and giving them to local residents and providers. And I think of the elected officials and other providers and residents. At the end of the day, however scary it gets, however uncertain it gets, at the end of the day, we are in this together, and we have been able to master every 20 minutes before us to get through this pandemic. Thank you.
Thank you, David. Thank you very much. All right. Please stay with us because Patrick Charmel, the president and CEO of Griffin Health, is going to be joining us as we change screens here. This is a remarkable story. Patrick began his career at Griffin as an undergraduate as a student intern while attending Quinnipiac University. After earning his master's degree in public health from Yale University, he joined the executive staff and rose to become president and CEO in 1998. Patrick also serves as chairman of Plaintree Inc., a subsidiary nonprofit organization dedicated to improving the care experience for more than 800 care sites across 25 countries. If that isn't enough, Patrick is also chairman of the Value Care Alliance, a collaboration of Connecticut hospitals, health systems, and physicians organizations, building the infrastructure for high-value, accountable care. During Patrick's tenure, Griffin has become an award-winning leader in personalized, humanistic, and consumer-driven healthcare. This is named among the world's best hospitals by Newsweek magazine in 2019. For 10 consecutive years, it was listed on Fortune magazine's 100 best companies to work for in America. In his 40-year career at Griffin, Patrick has never faced a challenge like this one. And he has done so, met this challenge with courage, fortitude, and grace. So Patrick, thank you so much for your leadership during very difficult times. Patrick Charmel.
Well, thank you, Bill. And it's a real pleasure to be on with you this morning. And where?
Presentation. See the left middle.
Here?
Yep.
Sorry, I was trying to bring up the presentation. It's a pleasure being on with you this morning, Bill, and with Jess and Fred and David. And Jess and David in particular have been fantastic partners. And I just want to give you sort of our perspective as we bring up the presentation. There we go. Just bring you our perspective in terms of the hospital response and what we're seeing in the community right now and the impact it's having in the hospital. And I'll move quickly. I want to leave a few minutes for questions because there was such great information shared. I think Jess showed you a slide of the number of communities that are considered as to having outbreaks. She showed you the latest weekly slide. This is a slide from the last week in October. So just in a short period of time, we went from this situation to this situation. And I know that we're almost getting used to hearing about the increased community spread, and Jess did share some information about how that translates for each of the towns in our community. And as you can see, the infection rate in the community is high. She mentioned that it's a function of testing. It is true that when this started back in the spring, the only people that we were testing were people that were hospitalized. So obviously they were very sick. Now we're finding folks in the community that are asymptomatic, but nonetheless, we are seeing increased community spread, and it's led to this. hospitals in Connecticut peaked in terms of the number of hospitalized patients with COVID-19 infection back in April. It was the third week in April that we peaked. And you can see during the summer, the number of hospitalizations dropped dramatically, and it's begun to build again. It's nice to see that in the latest week, compared to the previous week, we have seen a slight decline. We're hopeful. It does vary by county, and you can see that New Haven County, the hospitalizations peaked a little bit higher than some of the other counties and hasn't dropped quite as much. But what you hear on the news is, what is the hospital's inpatient capacity, particularly focusing on the number of ICU beds that are available. And I just wanted to give you a picture of what's going on both statewide and in New Haven County. So you can see over on the left, statewide, currently, as of yesterday, we're using about 76% of the available beds. It's a little bit higher in New Haven County at 78. The most important is ICU capacity. As Dr. Browne said, we're seeing fewer patients winding up in the ICU, thankfully. It's because we know more how to manage this disease, both in the community and here in the hospital. And you can see in the state, we're using about 61% of our ICU capacity. So you've heard reports across the country at 80 and 90%. We're well below that. It is higher in New Haven County, but we do have more ICU beds because we have a large academic medical center. So I wanted you to know that despite this increased community spread and this increase in hospitalizations, we do have capacity. Just in terms of our ability to manage patients, it's a little bit different now than it was in the spring, because in the spring, we did close down essential services, elective services. We stopped doing elective surgery, interventional radiology, screening colonoscopy, and we were able to redeploy staff from those departments to take care of inpatients in the hospital. We haven't done that. So it's a little bit trickier now. Plus, because of increased community spread, we're seeing caregivers and their families contracted COVID-19, and they then have to be out of work. So that is diminishing our capacity somewhat, but we're keeping up with the demand. Obviously, we're concerned about the holidays coming. We saw a spike after Thanksgiving. I thank Jess for her advice and how to stay safe during the holidays next week and into the new year, because if we see another spike following that, we might actually exceed capacity. You can see the number of cases that were confirmed. This was a couple of weeks ago. We're now up to 157,000 confirmed cases in Connecticut. And unfortunately, the deaths in Connecticut have increased from the 5444 shown here to 5,500. And as Jess mentioned, most of those deaths, not only in our community, but statewide, did occur in nursing homes. That number is around 4,500. That number of nursing home deaths prompted the state to be very aggressive in instituting a weekly nursing home testing program for not only nursing home residents, but also nursing home staff. But they had to build the infrastructure and capacity to do that. We got a call the last week of May by the Connecticut Department of Public Health, and the conversation went something like this: you're providing laboratory testing in 12 nursing homes here in Connecticut. Would you be willing to begin doing weekly COVID-19 PCR testing for the residents and staff in those nursing home facilities? And we said yes. That quickly expanded, but we needed a testing partner. So we are actually doing the sample collection, going in and swabbing patients, and all of the support that goes around that in terms of data aggregation, order generation, data entry, doing the swabbing, taking the specimens to the laboratory and doing the results reporting. We had to find a laboratory with capacity Rather than using a large national laboratory, we partnered with Jackson Laboratory. You may remember Jackson Laboratory came to the state back in 2012. There was a lot of fanfare at the time, some criticism because the state provided tax incentives just under $300 million. But frankly, we're grateful that the state did that, because Griffin and Jackson together have grown to be the largest testing enterprise in the state of Connecticut. We are now testing in 114 nursing homes here in Connecticut. And Griffin has built the infrastructure to do that. These are some photos about the various functions that we had to create, which includes data sourcing and data entry. It's a very complex and demanding process. It requires a lot of attention to detail, and we had to hire lots of folks and actually create some technology to do this work. We actually have to produce the media that when we collect the specimen, it has to go in what's called transport media. There's a national shortage of transport media and swabs. You've probably read about that. If we were going to do testing across that many nursing homes in the state, we couldn't rely on the typical supply chain. So we actually got into the manufacturing business, and we're actually manufacturing our own transport media here in the hospital. And to give you an idea, we're actually producing 40,000 of those tubes that you see a week here in the hospital and distributing them to nursing homes and a number of other sites, which I'll tell you about quickly. We actually have to prepare all the supplies that the collection specialists need on a daily basis as they travel around the state. This is, and you heard David talk about unemployment. We're very sensitive to this. One of the reasons we took on this challenge is we knew it would create an opportunity to employ a large number of individuals at a time where unemployment in the Valley grew dramatically. So for this project, to do testing across the state, which by now we're doing about 35,000 sample collections a week, we hired 180 people. Average salary for those individuals is just under 40,000. We have some people who are doing sample collection for us because of the hours that they're working, are generating an annualized salary of between $60,000 and $70,000 a year. And you can see unemployment. David didn't break it down by education level, but I did. And you can see of the 148,000 unemployed here in the state of Connecticut, you can see the vast majority of those are individuals with high school or less education. This project gave us an opportunity to hire from that pool. It also allows us to address a problem in the community David also referenced, is that we have a number of households in this community, especially in the African-American Latinx community, where incomes aren't sufficient to cover basic living needs. So in our hiring for this project, we tried to hire from those communities to give them opportunity, to allow them to increase income, but also to give them the skills they would need to get employment after this project is over, which we expect to run through March. And you can see that more than 50% of the population hired are from minority communities. And this is something we're proud of, and we've found very talented individuals who are confident will find jobs for either here at Griffin or in the community after this project ends. So again, most of what we're seeing in the community in terms of the number of cases and the number of deaths is in nursing homes. The number of nursing homes with outbreaks in Connecticut continues to rise. Luckily next week, CVS and Walgreens will begin to vaccinate nursing home residents here in Connecticut and nursing home staff. That will begin to hopefully the beginning of the end of the pandemic that's hit nursing homes so hard. This is our specimen collections per week. So you can see this has been a Herculean effort. You've heard large health systems here in Connecticut like Hartford Healthcare talk about their testing enterprise and advertising that they're the largest tester in the state. That's not true. Although Hartford Healthcare is 10 times the size of Griffin Hospital, we're actually doing more testing than Hartford Healthcare across the state, probably 20 to 30% more. Here's the positivity rate in nursing homes. Again, looks low, but when it occurs, when there's a positive case in a nursing home, for a lot of reasons, it spreads very quickly. And as I said, 80% of the deaths in Connecticut have been in long-term care. Jess pointed out our community testing. So in addition to nursing homes, we're also testing in the community by appointment on campus, but no appointment necessary in our other testing facilities, which are at Ion Bank, on New Haven Road in Naugatuck, at Tungus Community College in Farmington, and Quasi Amusement Park. We're also now in Trumbull, and we're exploring the possibility of opening another testing center in Bridgeport. And just quickly, you can see the number of specimens we've collected by location. So our testing sites on campus here at Griffin, off-site now, it's probably close to 10,000 specimens collected, tests performed in those community drive-through sites. We're doing testing in state universities. They're on break now, but those are across the 4 state universities. We're providing testing in state facilities, the Department of Corrections, DEMIS facilities, Department of Developmental Services. So we're the trusted and most important testing partner for the state of Connecticut. We are obviously doing outpatient testing referred by our physicians and in our emergency department. And as of today, by the end of today, we will have collected over 500,000 specimens and performed 500,000 tests. And again, that's those 180 individuals who are true heroes. They put themselves at risk, and in environments where other people just wouldn't go. So we're very proud of them. They are the healthcare heroes. They're very courageous. We appreciate the support of David and Jess and all those in the community who've helped us respond to something that's been a huge challenge, but together we've been able to overcome it. We still have a little bit of a way to go. We expect our testing program, as I said, to continue until March. By March, we expect that a number of people here in the state will be vaccinated, not only in institutions like the hospital and nursing homes, but throughout the community. And maybe during the questioning, we could talk a little bit about the vaccination effort. Griffin is a vaccinator for this region. We've begun this week. As of today, more than 500 of our staff will be vaccinated, and hopefully all of them by next week. So Bill, let me end it at that. I know I went quickly, but I wanted to leave some time for questions.
Thank you, Patrick. And I think I'm back, Nancy.
Yes.
Okay, thank you, Nancy. Patrick, thank you very much, and hats off to those frontline healthcare. That's an extraordinary number to end on. 500,000 happened on is really extraordinary. Pat, many of the questions have been answered in the chat box, and those that have not, in the interest of time, I want to tell our audience that we have recorded this, which and will include, of course, the slides. And we hope that you will share this with your associates within your organization. We'll get this out as soon as possible. Pat, I know you have an important engagement today at 10 o'clock. I want to thank you, Dr. Fred Browne, Jess, David, and Patrick. That was just an outstanding presentation. We leave on a hopeful note. I'm going to leave you by completing this holiday outfit. No holiday outfit is complete without a mask, as each of you have pointed out. So I want to model the behavior that we'd like to see, particularly over these upcoming holidays, to keep us safe. And we all, our hearts are broken for, just points out, the 263 of our fellow citizens who have lost here in our valley, the 5,500 in our state, 1.6 million across, the 1.6 million across the world, our citizens across the globe. So let's keep them in the families in our hearts this holiday season. Please be safe. Thank you all. Let's look forward to a better 2021. So with that, we're going to sign off and wish you all very happy holidays. Thank you, Patrick, Fred, David,